Just a little bit about me. I did my undergraduate education at Rutgers University School of Engineering. I was a biomedical engineering graduate. I stayed in New Brunswick for Robert Wood Johnson Medical School. I then did my residency in Manhattan at Mount Sinai and St. Louis Roosevelt Hospital Centers. And then I went out to California for a year, and I managed to make it back to New Jersey after spending a year in Sacramento at UC Davis. And now I'm an attending surgeon at Monmouth University Medical Center, Jersey Shore, Ocean Medical Center, Bayshore Medical Center, and soon to be Central State as well. Although I do primarily operate out of Ocean Medical Center and Monmouth Medical Center. And then I'm sure most of the people here know about Seaview Orthopaedics. We have providers in all subspecialties of orthopedics, from spine surgery to pediatric orthopedic surgery, and we have 6 offices, with our newest one being the Holmdel location. So what is spinal stenosis? So it's essentially a narrowing of the space available for the nerves. The picture on the right, you're looking at the spine from the top down. I'm just going to move this out of the way so I can use my mouse. Can you see my mouse? Is that possible? Okay, good. And so the disc is in the front, and the shell of bone that protects the nerves is here, and the nerves live inside of here. And you can see, compared to the picture on the left, there's much more white space, and you'll see shortly how that's where the nerves live. And essentially, it's derived from the Greek word stenos, meaning narrow. Hopefully I'm pronouncing that right. It's one of the most common conditions affecting the aging population. In adults older than 65, it's the most common reason to undergo lumbar spine surgery. Now, to understand spinal stenosis, it's helpful to understand a little bit about the spine in general. So there are 2 major mobile areas of the spine, the cervical and lumbar spine. And then there's the relatively immobile thoracic spine, which, thanks to the rib cage, does not move very much. And then there's the completely immobile or fused together sacral spine, which is the lowest portion of the spine. And then the lowest portion is the coccyx, which is the tailbone, which is part of the tripod that we sit on. Now, much like any either mechanic or engineer would know, things that move tend to break down. And the same thing goes for the cervical and lumbar spine. Yes, they are built to last, but how long? And for some people, it's sooner rather than later. Some people go their whole lives with no spine problems, but I gather that most of the people here are listening to this conversation because they have some problems in their spine. And the reality is that in some people, they have heart problems or blood sugar problems. And in a lot of people, that problem is arthritis of the spine. Moving on to this picture of these various pictures here, what we're looking at is the bony anatomy of the spine. And so what's important to recognize, looking at it from the back here, this is the shell of bone that protects the nerves. And the picture on the right here, we have the vertebrae, which hold about 2/3 of the weight of our body. The discs in between them, which work as shock absorbers and absorbing the up and down pressure. But then there's a very infrequently talked about portion of the spine called the facet joints. And these little joints back here. And these are interesting because they're what we call diarthroidal joints, similar to a hip joint, a knee joint. They have cartilage, they have joint fluid, they have a capsule. And so they're prone to get arthritis. And where they exist is literally right as the nerve exits the spine. So this picture on the top is looking at you from the feet down. So is this one over here. And the spinal cord is running up and down the spine, just like up and down me. But then coming off the side out these tunnels is where the nerves exit, called the foramen, as I have labeled here. This one, this labeled here, the foramen. And that is another area that the nerves can be entrapped. Briefly, looking at the soft tissues and the ligaments, we often talk, and a lot of patients come in to see me about lumbar strains. They throw their back out. And what does that mean? Well, sometimes that means a disc herniation, and sometimes that means aggravation of arthritis, but a lot of times it means a soft tissue injury. It means spraining or straining, which is a partial tear of the muscles or ligaments of the spine. So in the front of the spine and in front of the vertebrae and the back of the vertebrae, we have the longitudinal ligaments, which are very strong, stout ligaments. And then in between these processes, all these little extensions of bone that I kind of point out here are this here, this here, this here. These are all anchor sites for muscles of the spine. And the picture on the right shows all of those different muscles. And some run up and down the spine, and some run just one vertebrae to one vertebrae. And these complex muscles are not muscles that we engage in. When we bend our elbow, we know we're using our biceps, like we know how to do that. But when you move your back, you're really moving a complex set of muscles. It's a very complex motion of multiple vertebrae. And when they don't function correctly, that's what leads to pain. And when you have an imbalance in these muscles, this is often the pain generator for patients. Now, when we talk about arthritis, the disc is one of the main things we talk about. The discs, the interior portion of the disc is a more gelatinous-like material. It's called the nucleus pulposus. And then the outer portion is called the annulus fibrosus, a harder portion. It contains the gelatinous material. It holds it in. And there's these molecules that are called proteoglycans. And what proteoglycans do is they attract water. So they suck and hold water in the disc. And that's what makes it a good shock absorber, is it's full of water. Now, as we get older, those proteoglycans break down. And because there's not good blood supply to the disc, there's not a good regenerative process. And unfortunately, right now, we don't really have anything to fix that yet. Hopefully, in my career, that's going to change. But as it stands now, we don't have a reversal process for that. We mostly can address the after the fact problems. So looking at the picture on the right, we see a grade 1 through 5 degeneration. The disc is nice and tall in the top left. And then on the right side is
I'm sorry, Dr. Nowacki. Marjorie? Okay, I muted her.
Okay, no problem. And then on the right side, we see an MRI slice. So this MRI, each picture on the right is an MRI slice equivalent to the actual gross anatomy slice to the left. And so what MRI shows is water content. So this white is water content. And as we see, as the disc progressively degenerates and the bones get closer and closer together, the disc gets more and more brittle, and the white is lost of the disc, and we see less and less space between the bones and less water content. And that a lot of times hurts, and that's the underlying cause of pain. Now, when you get a fissure or a crack in the outer portion of the disc, that gelatinous material on the inside can herniate or push outwards. And this diagram illustrates the various places it can go. So in the top right, we have the most common location called a paracentral lateral recess herniation. And what that does is it traps the nerve against the bone, and it physically pushes on the nerve. And that external pressure actually is higher than the pressure of the blood supply getting in. So when we talk about your blood pressure, your doctor wants to make sure your blood pressure is under good control. Well, sometimes people with spinal cord injuries, we want them to have high blood pressure. Now, I'm not talking about your run-of-the-mill disc herniation. I'm talking about a traumatic car accident, but we are talking about the physical pressure of that blood getting in to the nerve. Is the lack thereof is what causes that radiating pain in your leg. Is the nerve is making noxious chemicals because it's dying, it's not getting enough oxygen, and that is what leads to the radiating pain. And there's other places it can herniate. It can herniate out a little further in the foramen, or it can herniate out in the center, in the central region. Now, I mentioned the facet joint, and I mentioned that I bring it up again because it's very important. So the foramen, this tunnel over here, this tunnel over here. When we look at this picture is an anatomy slide. It's a direct cut through someone looking at you from the side, okay? And so what we see is the NR is the nerve root leaving the spine. Now, this nerve root has this much space. This is about 20% or less of the space it's supposed to have. And what's happening? Well, it's being occupied. You see this O? That means osteophyte. That's bone spur. So this is not supposed to be here. This is not supposed to be here. This LF ligamentum flavum, this is thickened with age. And all of these things lead to a gradual compression and decreased space until the nerve has so little space that it literally doesn't have oxygen in anymore. And then it starts to hurt. And that's what causes radiating pain. It's one of the things that causes radiating pain. And this is an MRI diagram. The bottom left is an artistic animation, but this is an MRI diagram showing the progressive compression. So good space, this is the nerve, the white is the fat around it. This is the disc material here. This is a little bit of fat left, and then this is complete occlusion. So the nerve is being completely crushed by the disc herniation. This is looking at central stenosis. So again, this is now the feet down picture. So we have the disc here, we have the facet joint here and here, and we have that ligamentum flavum here, and the nerve or the cauda equina is here in the center. And you can see how in a triangular fashion, it all compresses and it all makes for less space. Now, this is a dynamic scenario. What I mean by that is that you can actually change the amount of pressure that's surrounding the nerves based off the position you're standing in. And we're going to get into that in just a second. So now looking at an MRI, this is what I'll show you in the office. I like to go through with all my patients their MRIs in detail. To give a little anatomy again, disc, looking at you from the feet up, shell of bone protecting the nerves, little dots of the nerves. This is, we can actually see the nerves, and the white is the fluid that surrounds them. And then a little bit of decreased space, a moderate amount of decreased space, and the bottom right, a severe amount of decreased space. And when we're actually talking about nerve compression, what are the symptoms? So that central compression, neurogenic claudication, okay, that typically presents as pain, heaviness, numbness, cramping, burning, or weakness in the legs. It usually starts in the lower back or the upper buttock, not uncommon for it to be in the buttock and not in the back at all. So I have patients that come in all the time and say, "Doc, my back doesn't hurt." When I ask them where it hurts, they point to their buttocks. And that's a very common location for it to start. And it almost always radiates down the legs. Oftentimes past the knee, but not always. Symptoms are typically worsened with prolonged standing or walking and can include a sensation of weakness. So when you are standing and walking, you are trying to keep your eyes level to the horizon. But what happens is that center area I showed you, when you stand up straight, it actually gets smaller. It actually puts more pressure on the nerves. And that's why people feel better when they hunch forward, when they walk with a shopping cart. I write in my notes, positive shopping cart sign. And what that really means is that the patient is flexed forward. They're making more space for the nerves, and they get better blood supply. So I have patients that can only walk to the mailbox and back or have to sit down. But if they go to the grocery store and they use a shopping cart, they can walk the whole store 10 times over. Now, when you get, they also tend to feel better riding a bike or walking uphill, all positions where you're bent forward. Now, lateral recess or foraminal stenosis, that's the tunnel pressure. That typically follows a single nerve distribution, meaning that it's in one leg only. It follows a very specific pattern. That tends to happen more commonly in younger patients who have a single disc herniation pushing on one space. Sometimes they can have weakness. That's actually a sign that surgery should be performed sooner before non-operative management. And sometimes it's worsened or relieved in certain positions because the nerve is like a string or like a wire. And when you think about it, when you pull that leg straight, you are pulling it directly into the offending disc, and that creates more pressure on the nerve, more pain. Now, there's something also important to understand. There is asymptomatic spinal stenosis, meaning not all patients with spinal stenosis have symptoms. Lumbar disc degeneration is almost universal with aging. Essentially, everybody past age 65 is going to have disc degeneration. In fact, disc degeneration starts at age 30. So, if you MRI'd everybody, I guarantee you're going to find disc degeneration. In fact, 20% of people over the age of 65 have significant spinal stenosis, but absolutely no symptoms whatsoever. And why no symptoms? Well, the reason is we think that is two things. One is that everyone needs a different amount of blood. Some people have bad blockages in their hearts, but have no problems whatsoever. They never suffer a heart attack their whole life. Part of the reason for that is what's called collateral blood flow. Collateral blood flow is the body, if the blockage on the top is bringing up blood from the bottom, reversing the path of blood flow sometimes is effective in getting oxygen to where it needs to go. And the other aspect is inflammation. And inflammation is one of the targets for our treatment. Okay, so inflammation, you need a combination of pressure on the nerve and inflammation in order to get radiating pain. And we know that because, like I just said, we have tons of people out there who have MRIs showing nerve compression, but not all of them have symptoms. Now, non-operative management, there is a reason we start with non-operative management. Well, first of all, who wants a big spine operation off the bat? Nobody. Everyone would like to know if they could have a non-operative management first. And the reason we can safely do that is that rapid or catastrophic neurologic deterioration is, thank God, extremely rare. Progression of the symptoms is often slow, and non or less invasive options can be very beneficial. In fact, a study that looked at patients treated looks at patients 4 years after the diagnosis of spinal stenosis found that 70% of patients had no change in their symptoms. So if you're out there and you're saying to yourself, oh man, did I really mess up by not getting treated so far? The answer is no. The odds are that you are, going to be the same. About 15% get worse, about 15% get better, but you can initiate treatment for this at almost any time. Non-operative management focuses on physical therapy, core strengthening, meaning your abdominal musculature, your oblique abdominal musculature, your lower back musculature. You can do this with a physical therapist. You can do this at home. I often give patients exercises right on their phone for them to do. You want to increase the flexibility of the spine. Our physical therapist can do therapeutic massage, electrical stimulation, ultrasound stimulation, a whole variety of things, ice, heat, a whole variety of things to try to help alleviate your pain. There's oral medications. Oral medications, typically people start off with Tylenol, ibuprofen, and then there are medications that are prescription only that are non-narcotic pain medications. So Celebrex or meloxicam is a common one. You have to do want to speak to a physician before starting these, because some people can't take them because either they're on blood thinners, they have a history of gastric ulcers, or a gastric bypass. So you do want to speak to a physician before starting these, for at least prolonged usage. Then there's a whole separate class of medications called neuromodulators. Medications like gabapentin, also called Neurontin or Lyrica or pregabalin. And these medications, basically what they do is they make the nerve more tolerant of the compression that it's seeing. So if the nerve is still just as compressed, but is no longer sending off those pain signals to your brain, then you don't have the pain. And that's a great option for some patients, especially patients who maybe are older, who either really are adverse to surgery, or they have a bad heart and they can't have surgery, and they don't want to be on narcotic pain medication there's a plethora of reasons not to be on narcotic pain medication, but they want something to help with their nerve pain. This can be a great option. I've had patients be almost essentially cured of their nerve pain with the use of these medications on occasion. And then for other patients, it doesn't work. For other patients, the side effects are too great. So this is part of what an office visit is about, is trying to figure out what are your options, what is the best care pathway, the best plan for you. Now, another thing that we commonly use, almost all my patients before surgery try, is a pain management injection. And those typically are epidural steroid injections. These are minimally invasive, same-day procedures done by one of our pain management doctors, most commonly often at a surgery center. And they're almost always worth trying before surgery. They're very low risk. And the goal, as I kind of mentioned before, is that, we know that pressure plus inflammation of the nerve is what leads to the radiating pain. So if we can knock out the inflammation, then we could potentially cure your pain. And we know that disc herniation sometimes can shrink in size, especially the younger the patient, the type of herniation is, etc. If you can bridge that person with 2, 3, 4 injections, you may get them to a point where the disc herniation has shrunk and they never need surgery. I like to tell the story of my wife. My wife had a disc herniation about 12 or 13 years ago, and she it took 3 epidurals, but she ended up not needing surgery for about 10 years. And then she had a reherniation event, injury, and then she eventually had surgery, and she's completely cured, and she does everything that she wants to do now, skis and whatever. But the point is that she had 10 years of relief. So that's a long time. The longer you can put off surgery, in my mind, the better. Surgical management is considered for those who fail conservative management, or for those who cannot tolerate their symptoms. The reality is that there are some people that are in such severe pain that physical therapy is just not an option. They try an injection, it doesn't work. That's how it goes sometimes. And unfortunately, those patients need surgery. And then there are other patients who have that, and we have to use some of those other medications that we talked about. Recent larger studies have shown better results with surgical treatment for spinal stenosis than continued non-surgical management. The goal, as I mentioned, is to relieve the pressure on the nerves, and that in turn will get rid of the inflammation. And sometimes this requires stabilization of the spine or fusion. Now, lumbar decompression or a laminectomy, that's where we remove the shell of bone or the pressure on the nerve. And it's easier to explain this in person. The picture on the right kind of shows this V-shaped piece of bone being removed. If in essence, what we're doing is we're giving the nerve a room with a view. It's got more space. Even if they don't take care of the disc herniation, the nerves can drift away from the pressure. Now, of course, we are going to take out the disc herniation if it's in a spot where we can do that. And we're going to leave behind these struts of bone, which are going to be the backbone that continues to provide structural stability to the spine if we're able to. Now, spinal fusion is something that patients have often heard bad things about, but the reality is it's a very successful procedure if done for the right reasons. The primary indications for a spinal fusion in my mind are either A, instability or slippage of a vertebrae, also called a spondylolisthesis, or B, pinching of the nerves in the tunnels as they exit, or foraminal stenosis, which I mentioned before. We're going to go back into that. On this picture on the left, I went ahead and drew the lines so it's easy to see the back of the vertebrae. You can see these two clearly do not line up. These line up just fine here, but not here. And when this occurs, there's already instability of the spine. Typically, there's back pain. And if you take away some of that bone, like I showed in the previous picture here, if you take away this bone, you're going to make that slippage worse. You're going to make that patient's back pain worse. So in those situations, you need to do a fusion. You need to stabilize the spine, stop it from moving. Going back to that foraminal stenosis I showed you before, well, here's the problem. The joint is right behind the nerve. So in order to get to that nerve pressure, in order to get to that disc herniation, we have to get rid of that joint. And when we get rid of that joint, I destabilize the spine. If I destabilize the spine, I must stabilize it to prevent the patient from having severe unrelenting back pain. And what happens in a fusion surgery? Well, it's actually fairly straightforward, believe it or not. What's done is a screw is placed along the vertebrae, in the safe channel of bone called the pedicle. This is done one on each side. And then these special screw heads allow a rod to be placed inside of the screw head and locked it into place. And that's going to hold the vertebrae in place. So here I actually have a little model. So, this is a three-dimensional model with screws growing into the bones, 4 screws in total, and then 2 rods, one on each side, held in place. And then the other thing I'm going to get into is the cage. There's a number of ways to do this. The most common way I do this is to go ahead and scrape out all of the disc material and then place a cage between the vertebrae. And you can see on this cross section on the right, a cage placed with bone graft in the center. So just like this, bone graft in the middle, and then screws held in place. And what that's going to do, okay, is that's going to rigidly hold this in one place. And what I will do is I will roughen up all the bone here and I will pack bone graft. That's going to act as the scaffold. And over time, that's going to create the struts that's going to rigidly hold these bones together. And that's going to create stability, the stability I mentioned that person needs. Now, I'll say it just one more time. Not everybody who needs surgery needs a fusion. In fact, my goal is to do as few fusions as possible because it's a bigger surgery, it's a bigger operation, and why do something the patient doesn't need? Now, the beauty of living in 2021 is minimally invasive surgery is becoming more and more common. We're taking the things that we've learned and doing it on a smaller scale. So if the problem is focal and it's just in one spot, well, why open up the whole back and do a huge operation? We can use these minimally invasive retractors like the tubular retractors on the right, or like these bladed retractors on the left to expose just a very small window of space, take the pressure off the nerve, and then through separate tiny incisions, put our screws and rods in, do everything under X-ray guidance. And in fact, we're even using navigation, which is a CAT scan guided screw placement. And we're using robots actually as well to help us place our screws and do things in a more minimally invasive fashion, make incisions in a perfect spot so you can make the smallest incision possible. In summary, spinal stenosis is common. It comes in many different varieties, as I talked about today. The symptoms almost always involve leg pain in some fashion, although not always. It can just be back pain. Although back pain is not a guarantee, but it is very, very common. Spinal stenosis can be diagnosed non-operatively. Most patients get an MRI. If you have a non-MRI compatible pacemaker or bladder stimulator or something like that, there are other options, CT myelograms. There are a number of things that can be done to get that diagnosis right. There are conservative treatment options available. Surgical treatment is available for those who don't well. The surgical treatment prescribed depends on several underlying components, as we talked about today. And don't forget to ask your doctor about the different types of surgical management options available to you, including minimally invasive surgery. Thank you very much. I chose to include this picture because it's as an engineer, it's an interesting picture. It's a matter of things gone wrong for somebody that I fixed, and they had multiple surgeries. that, had either I think they had broken down, and then they had another surgery by someone else and it didn't work. And you're now dealt with a problem. Now you're facing a problem where there's instability of the spine. There is a lack of fusion at multiple levels. There's severe pain, and you have to figure out what is the best way that I can stabilize this person's spine. And in this example, it utilizes anchoring bolts or screws to the pelvis, much like you build the skyscraper. You start with the bedrock, you put the screws into the bedrock or the pelvis, and then you build up rods around it. And those are your central struts. And then you build, and then you attach each level of the floor as you go along. And I think, to me, that's something that interests me. I'd prefer if not every surgery was like this. I'm very happy doing simple surgeries, but these make my job very interesting. And then just a couple of pictures of the things that I like to do. And my mom said that last time I didn't include her in a picture. So here she is, Mom. Hi, Mom. And hopefully I don't turn anybody away being a Giants fan. I'm always happy to have a friendly banter about sports in the office. So thank you all for listening, and I'm happy to take any questions at this time.